Well, good morning, everybody. The board secretary has confirmed that we have quorum, so I will call meeting 18 of the Board of Health to order. Welcome to wherever you are, be it at home or in the office or elsewhere. This meeting is being held using the city's WebEx technology with directors, staff, and registered speakers connected by video or calling in. While under normal circumstances, we would not be able to hold a virtual meeting of the board amended its meeting rules on May the 7th to allow it during the COVID emergency in accordance with the Municipal Emergency Act of 2020. Once the emergency is over, we will return to holding our meetings in person. Because we are meeting remotely, we'll ask for your patience with any delays and technical issues. And I would remind that members of the public can watch the meeting live on YouTube at youtube.com/Toronto City Council Live. We currently have 2 registered speakers. Registered speakers will be connected by audio. I would like to remind all members of staff, and for that matter the board, to keep your mics muted while the meeting is underway, and to members of staff to keep your videos turned off unless you need to join the board. As part of each agenda item, I will ask directors to raise their hands and unmute their mics if they wish to ask a question or speak. Of course, as we've done in the past, when voting on items, we'll do so by hand, and if a recorded vote is necessary, we'll turn it over to the recording secretary. Although we are meeting in different locations and meeting remotely today, the Board of Health acknowledges the land we are meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. Let me begin by seeing if there are any declarations of interest under the Municipal Conflict of Interest Act. If you have an interest, please raise your hand or unmute your mic to let me know. All right. Seeing none, may I have a motion to confirm the minutes from our board meeting on June the 8th, 2020? I see it's been moved by Councillor Perks. By way of a show of hands, all those in favor? Any opposed? Seeing none, that carries. So we're now going to proceed with a review of the agenda. The first item is HL 18.1, TPH's response to COVID-19, contact status update and next steps. We have 2 speakers and a detailed presentation. Our next item is HL 18.2, 2020 Board of Health Committees and Appointments. We have no registered speakers. I have an amendment I can move here if it's the will of the committee. This is to formally appoint members. I've heard from directors who have reached out. So I can move that here if people would like. So I'd ask the recording secretary to put that up. And so based on outreach I've received, this would be to appoint the following directors to the Budget Committee, as well as directors to the Performance Appraisal Committee, and to reappoint Director Mulligan to the Alpha Board of Directors. So I will move that. Let me open it up. Any questions? Okay, seeing none. All those in favor, by way of a show of hands. Opposed, if any. That carries. All right, and move to adopt as amended. By way of a show of hands, all those in favor. Opposed, if any. That carries. Next item is item HL 18.3, service agreements awarded and executed by the Medical Officer of Health for 2020. These are the service agreements coming out of our previously endorsed budget. Would anybody like to hold that item down, or is there a mover? Okay, seeing none, to move that item, I have Director Peter Wong. All those in favor? Opposed, if any. Seeing none, that carries. All right. And the next item, we have item HL 18.4, appointment of Associate Medical Officers of Health. There's a staff report with recommendations as well as a confidential attachment here. Would anybody wish to hold down that item? Okay, seeing none. Director Johnson, would you like to move that? You have the nicest living room by virtue of the background, so I'm turning this one to you. All those in favor, by a show of hands. Opposed, if any, that carries. And then our last item is a new business item, which I would now like to introduce, and it will go live, which is advancing a public health approach to community violence. You'll see very specifically last year in the fall, we dealt with a public health approach to community violence at this board, and the new business item is asking for an update and a report back in the fourth quarter of 2020 on the status of that work. So it is a request for a status update. As this item is just being put on, I would ask directors if we can add it to the agenda, but it will be held so that people have time to review it. So I would ask a motion. I would like to move that this item be added to the agenda. All those in favor? Opposed, if any? That is carried. Okay, so that means that we have on the agenda item HL 18.1, Toronto Public Health Response, and then we also have the new business item, which I believe is pretty straightforward, but we won't deal with it now so that members have a chance to take a look at it first. So we're going to go back to our first item, which is the main item in business in front of us. We do have 2 registered speakers, but what I'd propose is that we begin with the presentation from Dr. Davila and her team. We will then go to our registered speakers before bringing it back into committee for questions. And with that, I will turn it over to our fearless leader, Dr. Davila.
Thank you, Mr. Chair, and good morning, everyone. Nice to see you. I trust you can all hear me. Just looking for a thumbs up. Are we okay there? Mr. Chair, am I clear on your end?
We can hear you loud and clear, thank you.
Okay, perfect. Just wanted to confirm. So good morning, everyone. Nice to see you on the screen. Looking forward to the moment when we can actually reconvene in person again. In front of you, we're going to be you'll see on the screen slides that we'll be going through. I would just like to acknowledge as well that in the middle of the presentation, I'm going to hand it over to one of my colleagues, Liz Corson, who has been intimately engaged along with many, many others here at Toronto Public Health on the data side of our work. She'll be taking you through a middle portion of the presentation, and then it'll come back to me. So let's get through the presentation and get with it without further ado. So update on the current COVID-19 data and trends. If we could go to the next slide, it's clear that COVID-19 continues to circulate as a virus here in Toronto. And of course, as we have been for several months now, we continue to manage and carefully monitor our local situation. So these are data on this slide as of June 29th, telling you what our current situation is on COVID-19 cases. Again, the slide tells you up to June 29th. To give you slightly more updated data that we reported yesterday for the 30th of June has us now at 14,391 cases. You know, we know that our figures continue to rise. We are seeing fewer and fewer new day-over-day increases in respective cases. We're now in the double digits. As you can see, we had an increase between the 30th and the 29th of 71 cases overall. On the plus side, our hospitalization numbers continue to decline. Here on this slide, you'll see as of the 29th of June, we had 214. Looking at data from the 30th, it's 209 and 52 in intensive care, also a decrease relative to what was being reported for the 29th of June. And as well, outbreaks continue to decline in the city at this point in time. You know, turning now to the next slide, you get a sense as to what the epidemic curve looks like in respect of this outbreak. And what is, I'd like to draw your attention to here is that this curve really does show the 2 outbreak story that we have here, which was hinted at the last slide. One, which is an outbreak within the community, and one which is more associated with outbreaks within the context of institutions. And as you can see as well by this slide, that recent activity, the most current activity in respect of COVID-19 in our community, continues to be driven largely by community cases. Turning now to the next slide, you can see in front of you here a map of the various neighborhoods in and around our city, showing the sporadic case counts over the last 3 weeks. As you have heard before, there are certain neighborhoods that are more impacted in respect of COVID-19 activity, and notably neighborhoods in the northwest end of the city are having higher sporadic case counts over the course of the outbreak, and is demonstrated here on this slide in the last 3 weeks. So I think you know, this is something that we're going to get into greater detail as we talk about our further analyses, and you'll hear a little bit more about that as we go through our presentation. Turning now to the next slide, just to give you a sense as to our monitoring dashboard, this was publicly launched on June the 12th, and it is a method by which we can communicate and demonstrate progress to our public on the COVID-19 response. Now, while the dashboard itself was launched on the 12th of June, we have been monitoring a number of indicators for much longer and have been monitoring the outbreak since its start earlier in the year. However, with the launch of this monitoring dashboard, we have this opportunity to, help summarize what our current situation is locally, using a core set of 4 indicators which align with the provincial reopening framework. And those 4 sets of indicators are as depicted here on this slide. You see there are 4 circles: virus spread and containment, laboratory testing, health system capacity, and public health system capacity. So with our monitoring dashboard, we provide on the first blush, as shown here, we have an overall status on how we're doing. And right now, that current overall status, using a red, yellow, green scale to indicate the progress, we are now currently at yellow. And these are based on data as of June 28th, primarily. So let's take a look at each of the indicator categories that we've just described. So turning to the next slide, looking at the data on virus spread and containment, we have seen consistent decreases generally in our case counts. We do have a few days where we get a few small increases, and you can see that reflected on the new COVID-19 cases indicator 7-day moving average, that is in yellow status. However, as you can see towards the middle and the right-hand side of this graph, hospitalizations and outbreak in institutions, those figures are continuing to stay in the green zone and moving in the right direction, demonstrating progress in those areas. Turning to the next slide, we're looking at the next category, which has to do with laboratory testing. And just a reminder, just a reminder that laboratory testing is something that is not within the control of Toronto Public Health. It is something that is under the provincial purview. Provincial testing has certainly climbed over the last little while, and the average has been about 25,000 tests per day through the entire province, with some days that have gone as high as 30,000 tests in any given day. That, I think, has created some challenges for the province and the laboratory system that they've established in meeting their goals around turnaround time for lab processing. As you see here on the left hand and the middle part of the slide, we're talking about the proportion of COVID-19 tests, new COVID-19 tests that actually meet their turnaround time indicators. The goal for 24 hours is 60% within 24 hours, and their other goal is 80% of tests within 48 hours. As you can see, these are in red because they are not meeting those goals. But certainly I know that there is much work happening at the provincial level to try to address this situation and to try to get faster turnaround times, as this is important in terms of timely follow-up, case investigation, and contact tracing in respect of new COVID-19 cases. As you can see on the plus side, on the right-hand side of the slide, percent positivity in respect of COVID-19 tests continues to decline, and that is a good sign. Next slide, we look at health system capacity, another indicator and set of indicators that is outside of our control as Toronto Public Health, but still very important. This has been green for quite some time, but you'll note on the upper right-hand side of the slide that we are now in the red zone when it comes to acute bed occupancy rate. And that's because the goal for this indicator is at 85% or less in terms of less than 85% in terms of acute bed occupancy. And this clearly has increased over the last few days. But it's not unexpected. We know that as hospitals and our healthcare systems start to engage in non-urgent procedures and start to ramp up their activities, that their acute bed occupancy rate will increase, but we are constantly watching, as I know they are, in order to ensure that healthcare is available for those who need it, whether we're talking about a need for COVID-19 treatment or whether we're talking about any other medical condition. Last indicator has to do with public health capacity. So if we could go to the next slide. This has to do with Toronto Public Health and what we are doing in terms of reaching COVID-19 cases and reaching contacts within 24 hours. This continues to be in the green thus far, and we have worked very, very hard on our process reviews to ensure that we stay in the green as much as possible. I will just advise that as the numbers get lower, as the number of new cases does drop, which is a good thing, you recognize that meeting the goals gets a little more complicated because it takes very little to move you off your off the goal and off the target measure. I think the other thing that's important to note here, we were higher in respect of reaching cases within 24 hours very, very recently. We are, as you know, well into our response. We've had a number of people working really flat out for many, many weeks now. So we have been trying to give some of our team a little time off, particularly during the summer. And we are also bringing on new staff, and it does take them a little time to acclimatize and to adapt to the work and become more proficient and therefore more timely in case contact and contact investigations as well. So if we move to the next slide, we're now turning to the socio-demographic characteristics component of our presentation. And I will hand it over to my colleague, Liz Corson, who will take you through this component of the presentation.
Thank you, Eileen. Can everyone hear me okay?
We can hear you, Liz.
I think you're good, Liz.
Great. Today, I'm going to present some findings that help us understand how the social determinants of health might affect COVID-19 infection and outcomes. At a very high level, this information has been shared with you previously, but today I'm providing some updated findings. But before I move forward, I want to acknowledge my privilege in society as a white, cisgendered, economically stable person. I recognize that there are many in attendance today that have expertise and likely lived experience in how social determinants affect opportunities for health and well-being. Although I do have some experience working with data to support health equity, I want to acknowledge that I'm learning and continually trying to better understand a lot of the context that affects these inequities that I'm going to be speaking about today. Next slide, please. We know in Toronto that the social determinants of health are the biggest drivers of health outcomes. Based on previous work by Toronto Public Health and other researchers and community organizations, we know that access to good health is greatly influenced by the environments in which we live, work, and play. Toronto's diversity is certainly its strength, but it also means that policies and programs focused on reducing social and health inequities are essential, and disaggregated data is needed to inform those strategies. COVID-19 is no exception. We first started hearing reports of COVID-19 infecting some populations of people more than others from the US and the UK. Racialized people seem to be particularly affected by severe cases of COVID-19. As you know, TPH started collecting data on Indigenous identity, racial group, income, and household size on May 20th, after the in-house development of our coronavirus rapid entry system, CORS. We continue to accumulate these data and conduct quality assurance, and once the data are sufficient to reveal meaningful findings, we'll be able to share them with partners and the public. We expect to have this information available shortly. In the meantime, to begin to understand how the social determinants of health are associated with COVID-19, we have been conducting area-based analyses, linking people with confirmed or probable COVID-19 to data at a small geographic area from the 2016 census. This method assumes cases share the general characteristics for the small geographic areas where they live. There are a lot of limitations to this method, but it does suggest some general trends that can inform areas that need further investigation. The analysis that we've done only includes sporadic cases or those that are spread in the broader community outside of outbreaks in institutions like long-term care homes and shelters. And this decision was primarily made in order to match the census data that we're using, which excludes congregate living settings. I'll take this opportunity to note that we have also looked at people who have died from COVID-19 using this method, but we're not reporting on that at this time though, because it's actually a good news story, because there haven't been enough deaths among community cases in Toronto for us to use these area-based methods to draw conclusions about people who have died. So I'm going to be reporting just on infection and hospitalization. Before I move to the next slide, I just want to emphasize that these are associations and we don't have enough understanding to be able to say any of these factors directly cause an increased risk for COVID-19 infection. Next slide, please. Area-based analyses uses the small geographic areas where people live to create 5 groups. And in the case of this graph I'm showing you now, the groups range from lowest income to highest income. These groups contain people from small areas from all over the city. This figure is showing COVID-19 cases by the percentage of people who live below the low income measure. The group on the left is the lowest income group, and the group on the right is the highest income group. You can see that in the lowest income group, 504 people per 100,000 have received a diagnosis of confirmed or probable COVID-19. That's more than 3 times as high as the rate in the highest income group at 162 cases per 100,000 people. We see a statistically significant difference between all 4 of the lower income groups in comparison to the group with the highest income. Preliminary individual data that we've been collecting also support these findings that people living in lower income households are overrepresented among people with reported COVID-19 infection. Next slide, please. This graph is showing COVID-19 hospitalizations by the same income groups. Note that the scale has changed on this graph to represent the lower number of hospitalizations, but the trend is similar, with the lowest income group having 58 hospitalizations per 100,000 people compared to the highest income group with just 25. We haven't been able to gather enough individual level income data on people who have been hospitalized to confirm these trends yet with our individual level data. Next slide. This graph shows COVID-19 cases by area-based group of the percent of newcomers to Canada arriving in the past 5 years. The trend here is similar. The bar on the left has the highest percent of newcomers and the highest case rate of COVID-19. And the bar on the right has the lowest percent of both newcomers and reported COVID-19 infection. The hospitalization trend for newcomers is similar. One of the many limitations of these analyses is at an area level, we're not controlling for confounding factors, which are other factors that might be involved in the relationship, in this case, between newcomer status and COVID-19. The bar on the left, which has the highest percent of newcomers, also represents some of the same people that were in the lowest income group in the previous slide. Next slide, please. We also compared occupation categories in areas with a high case rate compared to areas with a low case rate. Occupation can be difficult to categorize, and the groupings presented here are broad and somewhat vague, but we are seeing some trends consistent with what's coming out in the anecdotal evidence. Certain occupations are overrepresented in areas with a high case rate of COVID-19, including people working in sales and service occupations, trades, transport and equipment operators and related occupations, and occupations in manufacturing and utilities. The increased risk of COVID-19 in areas with high proportions of essential workers is further supported by occupation data collected through our case interviews. Among Toronto's COVID-19 cases reported in May and early June, the most commonly reported occupations were factory workers, like warehouse workers, manufacturing and supplying workers, retail and customer service workers, and several healthcare related occupations such as personal support workers, long-term care home workers, and nurses. Next slide, please. This This last graph that I'm presenting is actually a newly reported finding, so this is the first time that we're sharing this. This graph is showing the COVID-19 case rate by area-based group of household crowding. Housing is considered suitable if the dwelling has enough bedrooms for the size and composition of the household. The bar on the left has the highest percent of people not living in suitable housing. So in other words, they're living in conditions that could be considered overcrowded. The bar on the right has the lowest percent of people who are not living in suitable housing. This trend is actually the most pronounced we've seen out of all of the different characteristics we looked at using these methods, with the case rate being almost 4 times as high among people living in areas with high levels of overcrowded housing. The trend seen for hospitalization by crowded housing is not quite as pronounced, but it's similar. This supports some of the anecdotal information learned from our case investigators, where concerns about housing are regularly being raised. Crowding is only one dimension of what is known as core housing need, which also includes affordability and also adequacy, which refers to the need for major repairs. Our analyses showed that core housing need as a whole was also associated with reported COVID-19 infection. Next slide, please. This table shows the racial group breakdown in areas with a high COVID-19 case rate compared to areas with a low case rate. The bullet at the bottom of the table highlights a key finding, but it also shows how this table should be interpreted. So this table shows, for example, that in areas of the city with a high case rate, 18% of the population identify as Black, whereas in areas with a low case rate, just 5% identify as Black. And this is compared to 9% of the Toronto population that is comprised of Black people. Other racialized groups are also overrepresented in areas with a high case rate, including Latin American people, South Asian people, and Southeast Asian people. In fact, all of the racial groupings we looked at were very different, except for the group Middle Eastern, where no differences were evident, and as such, I've not presented that here. But you can see on the slide that some groups are underrepresented in COVID-19 cases, including East Asian people and white people. The preliminary findings from our individual level data also support these findings, illustrating COVID-19's disproportionate effect on specific racialized groups. I'd like to take a moment here to acknowledge that I'm not presenting any data on people identifying as Indigenous as a part of these findings. We know that Indigenous identity is a very important social determinant of health, but Indigenous people are underrepresented in a lot of the data sources that we traditionally use in public health in Ontario, which is why we can't speak to how Indigenous peoples are affected by COVID-19 based on the evidence currently available to us. We've been engaging with Indigenous stakeholders in Toronto to collaborate on how we're collecting these data on Indigenous identity and how their data are being analyzed and reported in a way that reflects the needs of their communities. Next slide, please. As I mentioned before, there are a lot of limitations to these area-based analyses. As for all of our COVID-19 data, we need to consider inequitable access to testing, particularly at the early stages of the pandemic, which could influence the results. But the opposite can also be true. Focused testing in areas where we're seeing a lot of cases could also lead to a clustering of positive tests among certain populations. It is true that the more you test, the more you find. The most important limitation, though, is that we don't know, based on the data themselves, what is driving these associations. We don't have direct evidence for the pathways through which these social determinants of health affect COVID-19 infection. Even though we don't have direct evidence, we can, however, name some of the usual suspects for these disparities, which stem from long-standing systemic health and social inequities. For example, there are historically rooted disparities in access to economic opportunities for people from different racial backgrounds. Racism and implicit biases entrenched within hiring practices mean that people from some racial groups, such as Black people, are not well represented in higher paying professions with good benefits. Newcomers and racialized groups are more likely to work in higher risk occupations that don't allow for physical distancing, including those deemed essential during COVID-19. There are structural barriers to prevention and reducing transmission for many of the most marginalized communities. You can't isolate if you live in overcrowded housing, and you can't stay home from work when sick if it means that you won't make rent. And if your access to resources that promote and protect health are limited, then you're less likely to be able to follow public health guidance. Factors that may increase the severity of COVID-19, leading to higher hospitalization rates in some of these traditionally marginalized communities, include chronic stress caused by systemic racism and other forms of discrimination, inequitable access to health and social services, potentially due to bias and gaps in cultural competency among some healthcare providers, and comorbidities such as chronic diseases exacerbated by these same social and living conditions that influence COVID-19. As you all know, this is a brand new virus, only discovered in January. New research is exploring what genes might make people vulnerable or resistant to COVID-19. And at this stage, we just don't know if this could explain any of the findings presented here. But we do know that the social determinants of health have historically resulted in a disproportionate disease burden in some communities. Next slide, please. However, once we have individual level findings, we may be able to explore some of these relationships more deeply. As mentioned earlier, once we've collected enough data and had time to conduct necessary quality assurance checks, we will release some of our individual level findings. Data will be able to inform specific actions to mitigate some of these inequities, which Dr. Davila will speak about next. In addition to the questions that we have added to our case investigation process, we're also exploring a strategy to collect more socio-demographic characteristics, likely from a subset of cases. We're partnering with the Health Commons Solutions Lab on this work, and we've begun discussions with academic institutions who may also be able to collaborate. We've also begun the process of engaging a broad and diverse network of community groups about these findings via the community response clusters, which are led by the Social Development, Finance, and Administration Division and the United Way. These groups include 10 geographically organized tables, as well as a Black resilience table and an Indigenous table. We're particularly focused on engaging with groups that serve and represent some of the racialized groups disproportionately affected by COVID-19 infection to better understand why these disparities may exist and how we can mitigate them. And with that, I'll hand it back over to Dr. Davila, who will speak a bit more about the steps we're taking to reduce these inequities.
Great, and thank you so much, Liz, for that excellent presentation and taking us through those data. That was fabulous. So now turning to the slide on mitigation strategies, Liz is quite right. She brought some very stark and important information in front of you as members of the board. And as we look at these and as we hear about these, we need to think about what kinds of strategies. It's absolutely critical that we think about what we might do, strategies and actions under those strategies that could be put into place to mitigate the disproportionately, those who are disproportionately impacted by COVID-19. And certainly, in order to do this well, this would have to involve active engagement of those communities who are impacted themselves. We have a number of ideas that we are actively exploring. These are still in their relatively early stages and certainly will involve engagement of those communities that are most directly impacted. Certainly, we know that better support for safe isolation, given the data that Liz just presented, comes to mind. Requesting that Ontario Health and the Ministry of Health, as our provincial counterparts in charge of testing, actually increase testing in those areas with higher risk through strategies like mobile units. We certainly know that there would be some benefit to targeting certain messaging or ensuring that messaging is being delivered in a resonant way to those areas that are higher risk and would benefit from better information and educational strategies. We certainly know that working with community organizations to help build capacity and understand the circumstances and to use COVID-19 data to help inform some of the actions and strategies that can be taken would be important. Certainly sharing this information, these data, so that they can be well incorporated within the work of the Toronto Office of Recovery and Rebuild and other partners to ensure that they are actually addressing these issues in their activities. And of course, longer term planning for systemic changes, for a more equitable system of health and social services. This is fundamental to the objectives of local public health. And we know that there are a number of different strategies and actions that need to be contemplated and actually moved from thinking into action. Things that relate to affordable housing, things that relate to strategies and policies that actually address systemic racism, social security reform, consideration of ideas, and perhaps implementation and testing of such things as universal basic income. These are just a few of the ideas that we're contemplating and actively engaging with partners on in order to address the situation as Liz has so well described over the last several slides. So turning now to the next section of this presentation, we'll be looking at the recovery efforts both from the province and at the City of Toronto. But going to the next slide, let's just remind and refresh ourselves as to what the objectives of the COVID-19 response were. They remain the same. They have been this way from the beginning, limiting the loss of life and preventing loss of life as much as possible, protecting the capacity of our healthcare system to respond to all needs, and of course, limiting the negative social and economic impacts associated both with the virus and the measures that were taken in order to manage and control and contain that virus. These goals continue to be extremely relevant, and the focus now is really about adjusting the balance between them and amongst them as we move from a more containment and response phase to one that is also balanced with, yes, still with response and containment, but with recovery as well as an active feature of that, of our work. You know, to put it simply, I think we need to learn. It's not just in Toronto, but certainly here in Toronto, we have to learn how to coexist with the virus as it circulates in our community and manage the risk as that it presents to our health as a community and to individuals. The challenge, of course, is that, as Liz rightfully pointed out, this is a new virus. And while we have learned much over the past several weeks, we are still in a learning phase and still understanding and have many questions yet that are not fully understood in respect of the virus. Those continue to be present. There are many questions that science has that have yet to be answered. And this is one of the challenges as we move forward. Our strategy to date has been to reduce transmission, largely through such things as physical distancing and the management of cases and contacts. And we know as we start to move increasingly towards reopening and recovery, that intensive case and contact management continue to be important. But we also know that because we are still learning and because there is still much that we don't fully understand, reopening has to be approached in a cautious and gradual fashion, and we must constantly be monitoring what the impacts of the changes that we put into place look like. So turning to the next slide, you'll recall that on the 24th of June, our city entered stage 2 in the provincial framework for reopening. What this means effectively is that there are more businesses, services, and public spaces that are opened, and ideally with measures in place in order to limit risk, recognizing that the virus does continue to circulate, albeit to a lesser extent than earlier in the year. Looking forward, and actually hearing some reports on the news today, we know that there are other areas of the province that are more actively looking at proceeding to stage 3. We certainly, have that in our minds in the future, but it is a question of ensuring that we have balanced out, all the necessary thoughts, precautions, and measures being taken in order to mitigate risk as much as possible, whether we're talking about specific virus risks or the social and economic harms that are part of what the virus has wreaked on our community. Turning to the next slide, just to give you a sense of the number of activities that we have been engaging in as Toronto Public Health in respect of reopening. We have been an active partner in the efforts to support reopening of businesses and services in our city, and we've worked on a number of initiatives. Certainly one key initiative would be the release and the regular revision, I should say, as well, or add, on reopening guidance documents in order that people have public health protocols to help them either safely start or expand their operations, recognizing that COVID-19 continues to circulate in our community. We've also worked with our city partners and city divisional partners on a variety of initiatives, active TO, ensuring that people have space to get outside and to engage in physical activity while supporting physical distancing, Cafe TO, allowing for expanded patios and sidewalk cafes so that restaurants can restart businesses in a safer way and allowing outdoor dining. Curb TO and Camp TO are just two other programs as well that we've been active participants in supporting as well. And of course, as I discussed earlier, there is as well the COVID-19 monitoring dashboard that helps us communicate to our public what our progress looks like. Turning to the next slide on outbreak management, just to give you a sense of what we are doing as Toronto Public Health to continue addressing the outbreak in our city. And some of these are reminders. You may recall that we developed and deployed a new information system to help us manage our cases and contacts in a far more timely and a far more efficient process that replaced the existing provincial case and contact management information system. We've certainly worked on a number of pilots to facilitate the more timely connection of information around new COVID-19 cases that are identified in assessment centers, facilitating their communication and our awareness of them in a more timely fashion by connecting directly with assessment centers. We have expanded our information system to go beyond just what is being managed on individual case levels. We are also now using that to support our work in institutional outbreaks and cases. And I think it's also really important to talk about how our technology partners have really helped us develop this software in a very timely fashion. In the middle of the pandemic, they worked very well with us to maximize the capacity of this technology. And we are, in fact, the first local public health unit in the province to fully integrate our information management system, the system that we're using to help us manage cases, contacts, and outbreaks, with the provincial laboratory information system. So this was incredible work, I think, on the part of our team here at Toronto Public Health and our technology services partners. And of course, we continue to recruit and develop our workforce that's required. We hit a very high number of cases on a daily basis for quite some time earlier this year. And this is very intensive and challenging work to do. We needed to make sure that we had enough of a workforce and enough resources. We're continuing to do that. And that is a very important work that we are continuing to promote and advance. Turning to the next slide, looking at actions from the province. We've certainly been in active discussions with the province to improve case and contact management through a variety of different solutions. We've talked to them about policy changes, about laboratory changes, and about what can be done to information technology solutions to help advance our work in this arena. The province has also stepped up in many regards, and I think we should give credit where that is due. They have launched a number of different tables and initiatives of where we've been invited to participate, whether it has to do with case and contact management, the better use of digital technologies to support the response of the whole health system, healthcare, and public health partners. They have announced a new COVID-19 case and contact management information system to replace IFAS, the old provincial system. That is the system that we ourselves replaced already. But the province is now moving forward with their own replacement initiative, which is a good thing. And we are certainly keeping very close tabs on that and actively engaged in conversation with the province on that. We are working through with the provincial partners on a variety of different endeavors to facilitate and to make that transition from testing to case investigation and contact investigation more efficient, more timely across the board. So just getting to the end of the presentation, we'll just take you quickly through. If we can go to the next slide, we're going to go through the recommendations that are made in the report. I won't belabor these slides, but let's move to the next. The first recommendation that's made in the report that's before you today is for the board to advocate to provincial partners and to federal partners around supporting the work that we are currently doing to establish a volunteer isolation and quarantine center system. Fundamentally, what we're trying to do is to ensure that there is effective, safe isolation circumstances that are made available for those individuals who are having challenges in achieving that safe and effective isolation. Liz, in her excellent presentation, talked about how this has been a challenge. You can see that in the data. We hear it from our clients directly when we're doing that case investigation with them. We feel that this is a very important recommendation to move forward, and we are looking for board support on this. Turning to the next slide, we're also seeking board support on our work with transportation services and the Active TO program, particularly to support vulnerable individuals and community for whom access to space for physical activity continues to be a challenge. I'll move then to the next recommendation. This is a recommendation in respect of socioeconomic data. As you've heard, it is incredibly important to better understand those subpopulations which may be disproportionately affected by COVID-19. And we want to be able to continue this work and to ensure that those who are engaged in recovery and rebuild efforts are well informed so that these aspects can be appropriately addressed and incorporated on the actions taken by the city writ large as we move forward beyond COVID-19. Yes, to address COVID-19 and its impacts, but I think that there is a moment in front of us now for us not only to address these circumstances, to better support our response to COVID-19, to better support our recovery from COVID-19, but also recognizing that changes that can happen in respect of the social determinants of health have impact that go far beyond COVID-19 and our ability to withstand its negative impacts. Finally, recommendation 4, just going to the next slide. This is again building on the earlier recommendation, a request that I work with the city manager and that the team at Toronto Public Health work with the city manager to support how we can design and implement those social determinants of health. I've already spoken to this, but we do know that this is incredibly important work. And again, it's not just about COVID-19. It is actually fundamentally about what is public health all about. It is about improving health status and reducing health inequities. This is the kind of work that we can do to support and bolster our COVID-19 response and recovery. But I know it's the kind of work that will serve us well far beyond COVID-19. And when COVID-19 is hopefully a thing of the past, I know that ensuring that we have actually advanced on these fronts will support health overall in our community and will become incredibly important as we seek to recover from COVID-19. So turning to our last slide, which is our concluding slide. This has really been a very significant response for us and a significant learning for us throughout. New virus only discovered in January. A humbling experience, I would say, for public health around the world, and certainly that would include us. However, we have continued to refine our approaches and we continue to learn from this very unprecedented situation. We are continuing to ensure that we are adding staffing resources and other resources in order to be able to respond to rises in cases, which we should expect to see as reopening happens. This is inevitable. One only needs to look at the activities south of the border to understand how significant that can be, if not well managed. We are continuing to develop our use of technology for more efficient and more timely connection with cases and our contacts. We're very working hard on piloting that isolation center that we talked about, one of the recommendations in the report. But this is only one of the activities that I think we need to advance. There are many others that we should continue to work on, and please know that those are continuing to develop. And of course, as we reopen, we are continuing to prepare guidance for various sectors, notably schools and childcare centers who have some very challenging circumstances to consider with a lot of uncertainty in respect of how best to continue to provide much needed educational and childcare positive circumstances while at the same time trying to mitigate risk. It is, I can't say enough how much of a learning experience this is, and how, while we've learned a lot about response through the past several weeks, responding and reopening simultaneously is still a new situation for us and something that we are still actively learning our way through. That is my last slide, but if the board will indulge me for just another moment, to take you or to end this presentation on a positive note, there are a number of personal stories that I just wanted to share with the board. Stories that and thank yous that our staff have received. I can't tell you enough how significant the work of our staff has been, how very challenging the situation this has been, but they have risen to this challenge time and time again. And I just wanted to share some stories with you that we've received from some of the residents that we've served through this pandemic. One has to do with one of our Toronto Public Health nurses, and I have her full name here, so I'm going to actually say it, and I hope she doesn't mind. Lisa Powell-Judd, who actually I've had the great opportunity to have some interaction with. One person writes that their family has had a 4-week interaction with Lisa, connecting almost on a daily basis. And the summary is that the resident says that she believes that Lisa saved their lives. She gave guidance, helped figure out a plan, prevented the situation from becoming a dire one. She was professional, compassionate, informative, responsive, non-judgmental, and kind. This is the best of public health practice in a nutshell. Another message regarding Amanda, who was described by this resident as the lifeline for their family. Parents suffering from COVID-19 worried herself as to whether she had contracted the disease, but said to our staff, always felt your support and knew that you were virtually holding my hand through this day in and day out. Again, remarkable. I can't say enough. The final one I'll tell you about is one of our hotline staff, Paige, who apparently really helped this client who has a number of challenges. Just for personal information protection, I won't get into all the details, but this individual, because of their many medical challenges, talked about how she's not used to kindness these days, not used to understanding, used to having to fight for everything. But, our staff was able to address her needs and actually made our client cry in a good way because she just felt so touched by the kindness that was shown. And a final one for our contact team, somebody who is away from their family, spoke to their parents back home about Toronto Public Health staff concern about them and the calls with daily check-ins, and just wrote to tell us that her parents feel much better about her safety and health being in secure hands. So, if I can, just thank you to those staff and to the entire team at Toronto Public Health. These are just a few of the stories. I can't tell you all of them, but there are many stories just like this. And it is our staff that, our amazing staff here that are responsible for this work. It has really required each and every one of us to push our limits, to engage sometimes in what I would characterize as extreme multitasking to respond to this unprecedented situation. And, I cannot thank our staff enough. I also want to just take the opportunity to say thank you to our many city colleagues and our external community partners in particular for their constant collaboration. Again, so very, very appreciated from all of us here. I again can't say thanks enough to those partners. And I know that there's much more we have yet to do. So I'm sure I'll get the chance to say thank you again, and to say that I look forward to our continued collaboration. To the Board of Health members and to the chair, thank you for your support as always. This unprecedented situation, I think, has taken quite a lot of all of us here at Toronto Public Health, but we know that you have been behind us, with us all the way, and for that, we thank you. And if I can, I would just make one final thank you to the people of Toronto for everything that they have done, for listening, for their cooperation, and for their continued efforts to control this virus and their continued efforts to take care of each other. Thank you to the people of Toronto. So with that, I do apologize for the rather lengthy presentation. Thank you, Liz, for your presentation, and I will hand it back to you, Mr. Chair.
Thank you, Dr. Villa. Thank you, Liz. We're now going to bring this, we have two speakers, so we're going to go to our speakers before we bring it back into committee on this item. Our first speaker who has joined is Josh Fullen from Maximum City. Josh, are you connected there on the line?
Yes, hi, Mr. Chair. Can you hear me?
I can hear you loud and clear. So Josh, you're going to have 5 minutes. I'll start your time here, and I'll give you a 30-second heads up when we're near the end. So we'll turn it over to you for your deputation when you're ready.
Thank you very much, and thank you to the committee for this opportunity to speak. My name is Josh Fullen, and I work for an organization called Maximum City. We have spent the last 3 months researching the impact of COVID-related closures on Canadian children and youth, ages 9 to 15, with a focus on Toronto. So what we did is we ran 2 parallel surveys, one specifically within the Toronto CMA, and then we ran a broader one coast to coast, and we reported on those 2 survey questionnaires separately in executive reports that I have submitted today for this committee. And I just want to speak a little bit to first the rationale for the study very quickly, and then some of the key findings that I think are consequential to this body as well. So the rationale for the survey was really to take a 360-degree view of daily life of Canadian kids, of their behaviors, of how they changed, of their feelings, of their school engagement, of the different dimensions of well-being, and really listen directly to kids while they were experiencing these unprecedented changes in their lives, and not as a retrospective. So the survey ran in the middle of May, kind of from the 10th of May to just about the end of May. And we collected 932 responses across the country, but just over a third from Toronto. Essentially, we wanted the findings from the survey and the study to be used as evidence in the recovery strategy. And our rationale for that is that the lived experience of kids and teens needs to be a critical part of an evidence-based recovery strategy. You can't have a full recovery strategy without using that key element. So in terms of some of the findings, I mean, there is some good news out there. Some kids report doing fine, and some kids report that they're even thriving. So the kids who say, I have more time with family. I got to know what mom does for a living a little bit more because she's working at home now, and I feel more respect for her now, and I've got more time with my brothers and sisters, or I have less demands on me from school, and I'm actually kind of a self-motivated learner who likes to go out and find passion projects. So those kids are doing fine. Some of them are even thriving, but there is a confluence of factors in kids and teens who are really struggling, and those 5 factors are less time outside, more time with technology, less physical activity, less engaging school, and less social connection. So when we see all of those factors come together in respondents, it's a very troubling sort of confluence of behaviors and well-being outcomes that we're concerned, can lead to a pretty serious mental health crisis if it's not addressed. And I think the bottom line is that all of these different sort of outcomes that we're seeing in the survey need a response that is not just a response to the status quo. And Toronto kids in particular, and I'll explain a little bit about this in my last sort of 90 seconds, are suffering worse in all of those five confluence of factors than their Canadian peers. So the negative impacts of COVID-19 closures on the behavior and outcomes of Canadian children and youth are worse in big cities, and particularly in Toronto. So compared to other Canadian kids and teens, young people in Toronto have fewer places to play or exercise outside of their home and less space to play inside. They go outside less frequently, and they feel less safe when they go outside. Toronto kids and teens are less physically active and spend more time worrying compared to their Canadian peers, and they're more worried about their families having enough food and a safe place to live. Their self-reported well-being outcomes, so these would be negative feelings that they are having more strongly since the pandemic began, are also slightly to moderately worse. And in terms of our recommendations in how to respond and limit the social and well-being impacts of what we're seeing in the study, we have prepared a one-page document that speaks to some very high-level recommendations. But I think it's really up to the divisions that make up the service and the growth and the guidance around children and youth to come up with further strategies as well. A lot of the focus is on school reopening, but there are divisions certainly within the city who can play a strong role in an effective and equitable recovery for children and youth. So Parks, Forestry, Recreation, Children's Services, Toronto Public Health, all of these divisions, in our mind, should play a critical role in the social recovery of children and youth coming out of the pandemic. And it's the last thing I'll say, I see that my time is up, is that it's hard to crystallize sort of 3 months of research and analysis in a 5-minute deputation. So I would really urge the committee members to take a look at the executive reports. They're very sort of concise, and take a look at the recommendations as well, and then follow up if you have any questions with me or my team. Thank you very much.
Thank you very much, Josh. I see that Director Peter Wong has questions. I believe you raised your hand, as does Trustee Donaldson. So if you could stay on the line, Josh. Director Wong, Peter Wong, you're up first.
Hi, Josh. Thank you very much for this excellent presentation. Well, it is actually very refreshing to see the voice of and hear the voice of children and their concerns, as this is one of the UN Rights for Children in their declaration. So this adds significantly to that. My question is, in your survey, did you disaggregate your data to see if children that are at more vulnerable situations are worsely affected or had significant benefits as well to home isolation? Maybe you can comment on that. Thank you.
Yes, thank you for the question. So we do have demographic data by household income and by racial background, and that analysis is currently underway and should be ready in about a couple of weeks. This initial sort of report was sort of the high-level analysis that we were able to do quickly when the survey closed, but we're continuing to do a deeper dive on segmented analysis. And we do have a representative sample, or a close to representative sample, for household income and racial backgrounds within the Toronto CMA. We could have had a much larger sample size, but we kept it small because we kept quotas on racial backgrounds and household income levels to make sure we had a representative sample, or a nearly representative sample, which is what we have. So that work is underway, Mr. Wong.
Thank you, Josh. I hope that you will share that with us as that develops. Thank you.
Thank you, Director Wong. Next up, I have Trustee Donaldson. Trustee Donaldson, when you're ready.
Thanks. First of all, thank you so much for this report and these recommendations. I'm really grateful to you and your organization for centering the voices of children and youth, particularly the finding and the articulation of it about mental health. I think for children and youth, that's so important to consider in the recovery. And I also want to just say that your findings match everything that, as a trustee, I've heard anecdotally from students and parents. And also, as a trustee at the TDSB, I just want to say that this report is so helpful to articulating the experience of Toronto youth. At the TDSB, we struggle to communicate to the province, in particular the Minister of Education, what Toronto youth and children are facing in particular. And I love that this also compares it against Canadian children. So thank you so much for that. It will be used and used well by us, and it'll complement the data that the TDSB is collecting from students over the course of this month as we prepare to return to school. So I really just wanted to say thank you and compliments.
Thank you, Trustee Donaldson. And I'll just add quickly that ours will not be the only study that shows this difference between urban kids and ex-urban and rural kids. So I know of at least 2 other studies that are sort of in the pipeline that affirm what we're finding is that the impacts on kids in Toronto and large cities like Toronto are worse because they have fewer places to play outside, sometimes smaller households, and they're spending more time with technology and all the sort of that confluence of negative factors. So you can look forward to seeing, unfortunately, more reports that sort of confirm our findings.
Thank you. Any other questions for Josh? If you want to raise your hand to indicate if you have any. Okay, seeing none. Josh, thank you so much for joining us here today. Our second and final speaker here today is Helen Chilas from the 1591 Woodbine Tenants Group. Do we have Helen on the line?
Yes, hello. Can you hear me?
Helen, welcome back.
Hello.
Good to have you join us again. You'll have 5 minutes when you're ready.
Okay, thank you. And good morning. My name is Helen Chilas, and I am a tenant advocate, and I'm also on the City of Toronto Public Advisory Committee on Affordable Housing. Today I'm speaking as a resident in our wonderful City of Toronto. I would like to commend both the Board of Health, Public Health, and City Council for leading the way to help curb the spread of COVID-19 in our city. Thank you. On June 30th, City Council voted in amendments to City Chapter 354 apartment buildings to help protect residents who live in apartment buildings, where hundreds of thousands, many who are disproportionately affected by the coronavirus. Best practice cleaning and disinfection, posting of public health signage, and the availability of hand sanitizers is now finally law. Undoubtedly, these measures will help curb the spread of COVID-19 in apartment buildings. Thank you. But why wait until July 15th for ratification? Why put hundreds of thousands of Torontonians at continued undue risk for 2 weeks? In my humble opinion, there is no rationale to excuse such delay. Time is of essence to mitigate risk to some of Toronto's most vulnerable citizens. Please reconsider amendments to the apartment building bylaw immediately and its ratification. I know it can be done quicker. Torontonians saw it in action on June 30th, where City Council voted in the mandatory wearing of masks within enclosed public spaces with just a week's notice, affecting 3.5 million residents and visitors to Toronto. This is good news, great news. Thank you again for taking leadership on the wearing of masks. But there is also a major problem here too with the rollout. City of Toronto Bill 511 to impose temporary regulations requiring the wearing of masks or other face coverings within enclosed spaces. Section 7 states, the following premises are not an establishment for purposes of this bylaw, even if they would otherwise fall within the definition. That would include schools, post-secondary institutions, and childcare facilities, private transportation and public transportation, and previous City of Toronto bylaws for hospitals, independent health facilities, and offices of regulated health professionals. So why did the city disseminate a press release on June 30th, which states the bylaw will not apply to apartment buildings and condominiums? Not apply to apartment buildings and condominiums, including lobbies? I'm not sure where this came from. Many media outlets have also been reporting that the mandatory of masks indoors does not apply to apartment buildings and condominiums, including lobbies, where bottlenecking can be seen daily as residents wait for elevators with restrictions of maximum 2 per elevator. This misinformation, if not immediately corrected, will undoubtedly cause confusion for millions of residents who live in congregated apartment and condo towers throughout the city. If not immediately corrected, this undoubtedly will cause a conflict of interest with labor laws, putting workers such as on-site staff, cleaners, contractors, delivery personnel, and the like in direct, unwarranted, increased risk of contacting COVID-19. This misinformation, if not immediately corrected, will undoubtedly put millions at undue risk of contacting COVID-19. Torontonians working and living in congregated apartment and condo towers throughout the city. Please correct this grave error immediately for the well-being, health, and safety of all Torontonians. The wearing of masks comes with its own controversy and conspiracy theories. We don't need that. It is important that we stay safe, healthy, and we move forward from the coronavirus. I know it can be done. Most likely it was a clerical error, and I would appreciate if it can be addressed as soon as possible. Thank you very much for letting me speak today.
Thank you very much, Helen. Let me open it up. Are there any questions for Helen? If so, if you would raise your hand to indicate so. Okay, seeing none. Helen, thank you so much. At this point, we're going to take it into committee, though I would recognize that joining us in committee here today, we have a visiting member of City Council, Councillor Perruzza. Welcome. And so we're going to move it into committee for questions of staff. I'll take a list here for questions. Do you want to raise your hand if you have questions of staff? I see Director Mulligan, Director Wong. Okay, keep your hands up for a second if you wouldn't mind. And Councillor Wong Tam, Councillor Lai, and I will, okay, so I have, let me just see, so I have Director Mulligan, Director Peter Wong, Councillor Wong Tam, Councillor Lai. Did anybody else have questions? And I see visiting member Perruzza. Okay, I'm going to begin with, as a courtesy to our visiting member, visiting Councillor Perruzza. I'll let you kick it off for questions, and then we'll take it into committee. Over to you when you're ready, Councillor Perruzza.
Perfect. Am I on? Can you hear me?
We can hear you now. Thank you.
Oh, thank you. Okay, perfect. So just a couple of questions of staff in dealing with this report. First of all, I want to thank you. I know you haven't moved our request yet, but I was asking the other day about some testing up in the northwest part of Toronto. As you saw the map earlier in the presentation, we're kind of like mid blue, dark blue, and then now there's a hot spot obviously in North Rexdale, just west of my district. That's very dark blue, meaning the cases of COVID are relatively high. Can you just describe briefly, if you move a mobile unit into the area, what do you get with the unit?
So through the chair, Councillor, my understanding, so this is, the mobile units are actually under provincial purview. So I don't know that I can speak particularly well to the details. My understanding, though, is that you do get a variety of healthcare professionals, who are able to conduct assessments of those who present for testing and then perform the test, the COVID-19 test, and submit it to the laboratory for analysis and then determination as to whether you've got somebody who actually has a positive case or who is a case of COVID-19. I think the other thing that's perhaps worth mentioning, Councillor, is that, you know, I admit I have not since Tuesday evening or afternoon have not had that opportunity to connect with the province, but my understanding is that there is active testing that's happening. My latest data suggests that there is some testing that is happening in the northwest end of the city. I don't have specific details, but I'm certainly happy to follow up and connect with you offline.
No, I know that some specific testing in a few key locations has taken place. I was having a conversation earlier this morning with one of our public health executives in the area, and I'm told that if you get the unit, and I know that you're going to be asking for it, you need a doctor or a nurse practitioner on the ground with the unit to actually issue prescriptions for people to get tested. Is that correct?
So there's not a prescription that's needed for testing. There is an assessment. So that was the healthcare professional I was speaking of. So it may be a nurse practitioner, it may be a physician, it may be a number of them, in fact, who are there to provide assessments and then conduct the testing.
And they automatically come with the unit. It's not that you have to go back to either you or the LHIN or one of the clinics or hospitals in the area to get these people. They come with the unit, correct?
So that's my understanding. So these units are actually put together, if we can call it that. The mobile testing facility actually does involve the collaboration with healthcare partners. Sometimes it's a hospital, sometimes it's a hospital assessment center, but they're part and parcel. The testing, the mobile testing needs the healthcare providers to actually do the assessment, to go with the unit, to set up shop, if you will, in that local facility or location, and actually do the assessments and actually perform the testing as well.
Okay. Now, I was also told that, so one of the problems that we're having from the experience on the ground is if somebody goes in and gets tested, and let's say they test positive, there's been very little follow-up. And I don't know who would be doing the follow-up with them to see if they've adequately quarantined, if they've been in contact with other folks. As you know, in many of these cases, there's language barriers, there's access barriers, they don't have phones. So, you know, a lot of people don't answer the doors when you actually physically knock on their doors. How is that being done? How is that follow-up being done?
So very briefly, through the chair, we've managed over 14,000 of these cases, and there is a regular, that's part of the case investigation process, to find out, to understand, you have a positive test, where might you have acquired this infection is one aspect of that investigation. And the second part is to understand who might have been exposed during the period of infectiousness, so we can then do the contact tracing and follow-up work. So we actually do, that's public health's work, and we do follow up with all of our cases.
And Councillor Perruzza, this is your final question. We're just over 5 minutes. Thanks.
Yeah, thank you so much, Mr. Chair. And so you're confident that you're doing that. You're actually doing that physical following up, and everybody's being followed up on.
That is the purpose of the case investigation and contact management process. But Councillor, I'm very happy to speak with you offline if that's helpful.
Okay, sure, yeah, thank you.
Thank you very much.
Mr. Chair, I'd also like to speak when it comes time to speaking on this, okay?
Certainly. And for citizen members of the board who've never had the privilege of a Councillor Perruzza speech, prepare yourselves. It is spectacular. So, Councillor, we're glad you're here. Thank you. Our next for questions is Director Mulligan, followed by Director Peter Wong. Director Mulligan, over to you.
Thank you, Chair, and good morning, Dr. Davila and Liz. Thanks so much for your presentation about the data, the disaggregated data that I hope is coming, and the evidence that supports what I think we all expected, which was that this would have a disproportionate impact on marginalized people who have been made marginalized by long histories of social and urban policy. So I'm very pleased to see that you're interested in taking some steps on that as well. And my question is, when might more of the individual level data be ready to share?
So perhaps I can start off with that. My understanding is mid-July, but Liz may be able to give you more specific details as she's closer to that.
Thanks, Kate and Eileen. Yes, we're working towards mid to late July. So we don't want to give a firm date yet in case we encounter any IT issues or any other issues that might prevent us from sharing the data more publicly. But yes, we're looking at mid to late July.
Okay, thanks. And the intention is to immediately start using that to help work on this phase and the potential next wave?
So through the chair, that's correct.
Okay, thank you. I wanted to know if you happen to have any data about the mental health and well-being of parents and caregivers during this time.
Liz, might that be something you can take on?
I don't think we have looked directly at mental health of well-being and caregivers. We are looking at mental health overall, and we're accessing a number of different and new for TPH data sources to look at that, including, for example, 211 and some call-in lines for people who call when they need mental health supports, and they can call for referrals. We can take a look at the data further to see if there's a way that we can stratify out parents and caregivers. It's obviously a very important population of people currently, especially people who are working from home with their children, which I can imagine is a massive struggle. So we can take a deeper look just to see if there's anything there that we can report specifically for that population.
Okay, thanks so much. I would like to hear, sorry, I'm getting a big echo. Anyone else getting that? Okay, I'd like to hear about that when you report back at the next meeting about the advice that is being given to schools and daycares and childcare facilities and so on around reopening, because I know that parents and caregivers have been operating under an emergency work at home, school at home, parent at home model for a long time, and we need to make sure that the assumptions made going into reopening schools and childcare centers don't rest on an inequitable division of that labor. And I'd be also very interested to see a gendered breakdown of how this is impacting women in particular. Thank you. Okay, so I do have another question for Dr. Davila. I'm interested in, I'm going to change gears for a second and just ask about masking. I know that you have now issued some guidance around that, and the council moved motion on this a few days ago. What has changed? We asked about this at the last Board of Health meeting. Has the evidence changed, or what has changed in your view?
So through the chair, things are constantly changing. There is constantly new evidence that's coming out. And I think if I had to summarize it very quickly, the science on masks is not entirely settled. But we do know that there is an increasing understanding of asymptomatic and pre-symptomatic transmission of disease. We certainly know that that there is increasing evidence that suggests that using cloth masks, or the use of cloth masks by the general public, does help prevent the transmission of germs from the wearer to those around them. We also know that as more and more people, as we move towards reopening, that there is more interaction between people, and it's just more challenging to maintain the physical distancing. So, you know, taking all this together, along with some new studies that show that the use of cloth masks may serve as a visual cue to remind people that as we're moving around, that yes, there is still a pandemic that's ongoing. you take all of these together along with the evidence on physical distancing, hand washing, and what have you. We felt that this was, a good thing to move forward at this time in order to enhance all the other public health measures that are in place and to move towards a successful reopening.
And Director, we're just coming up on 5 minutes if you have one last question.
Okay, for my last question, I'm just going to ask about long-term care. If you can provide an update about the policy around visits by family members who are essential members of the care team.
So just very briefly through the chair, this is something that I know is being actively looked at, and this is something that's happening at the provincial level. So those policies are actually set by our provincial counterparts. Certainly we have some opportunity to discuss with them what the policies are. And there is still very active conversation around who can participate and who can come and attend at those facilities and what the requirements are. Certainly local public health and other community stakeholders have expressed some concerns around the current testing recommendations. That conversation continues. It's still very much an active conversation. But it is ultimately at the provincial discretion, as they're the ones that are responsible for the regulation of those settings, long-term care homes.
Thank you.
Thank you very much. Next, I'm going to turn it over to Director Peter Wong. Peter, when you're ready, it's over to you.
Thank you, Mr. Chair. Thank you, Dr. DeVella and Liz, for that excellent presentation. Very informative on disaggregated data. I want to thank the whole Toronto Public Health team for their outstanding and excellent work through this troubling time. My question really is around next steps. And as we start to open up, I think people are beginning to get this false sense of security. And people are becoming less careful about physical distancing already, and we're just barely starting to open up. And we really have to look at what's happening. So my question really is around how are we going to maintain good vigilance and good social behaviors, especially in the young people, because that's the next group that we see that the positive cases are increasing. What is Toronto Public Health doing to target this kind of false sense of security, especially in young adults? Thank you.
So through the chair, excellent questions in respect of next steps. And certainly we're concerned about ensuring that people continue the good practices that they've been demonstrating over the past several weeks. As I alluded to in my response to the earlier question, there is some science that shows that actually the increased uptake and the increased use of masks and face coverings does serve as a visual cue. Science is continuing to develop on this, but there are more and more studies that demonstrate that having those visual cues, reminding people by seeing people wearing masks, actually does help to promote physical distancing and the other important public health measures. So we will be monitoring for that. And one of the other things that we are just exploring now is that we're engaging with behavioral scientists and other researchers who have expertise on, how do we create circumstances and environments that actually promote the right kinds of behaviors, good behaviors in respect of containing COVID-19. That this has been used in the United States, it's been used in the UK, and to a certain extent here, these behavioral insights or nudge units, you may have heard of these policy shops within government. There are a number of researchers, academics, and these policy outfits that work on this. We have initiated some conversations with those academics and research types in order to try to see what we might be able to do. Of course, there are also communications endeavors, better use of social media, and trying to understand what the motivations are of young people and to see how we might be able to work with them better to make messages resonate in a way that is meaningful to them.
Thank you. I think we certainly look forward to hearing about that and see how that action plan rolls out. Thank you, Dr. Davila.
Thank you.
Thank you very much, Director. Our next, I have Councillor Wong Tam, followed by Councillor Lai. Councillor Wong Tam.
Thank you very much, Mr. Chair. Thank you, Dr. Davila, again, for all your hard work in this excellent presentation. I have a question regarding the socio-demographics piece of it. There's talk about income. I see that as a highlighted category, and there's also a highlighted category around housing suitability. For those who have no income and no housing, including a growing population that is finding themselves living outdoors, either in encampments or under bridges and other places, your presentation didn't capture that group. Is that correct? Or is there a separate slide that perhaps just does not speak to that?
So through the chair, you're quite right. The presentation didn't really focus on those particular groups. I may ask Liz for how we have broken down our data to capture those who are experiencing homelessness, which I think is what you're getting at, Councillor.
Correct. Thank you.
Sure. So the data that we presented today, unfortunately, relies on census data, which doesn't capture populations experiencing homelessness. I think that one way that we can identify people who are experiencing homelessness in our data is, I'm getting a low bandwidth sign. I'm not sure if people can still hear me, but I'm going to continue. One way that we could potentially address that is in our data in cores at an individual level, we do have the source of the transmission or the outbreak captured. So for example, we do know cases of COVID-19 that people are experiencing who are living in shelters or who are visiting shelters. So that is one way that we could pull that out. I'm not sure if FE on the line wants to speak to that further. I don't have direct access to those data currently, but we could explore and report back potentially as well.
That would be helpful, I think, just because there's we don't want to leave anyone behind, and we recognize that this is the most vulnerable population. They do not have the luxury or the benefit of isolating at home because they're not in a home. And I recognize that Shelter Support Housing Administration and, of course, the incredible team at the city that has been building the response around COVID for those who are homeless. Some people are now indoors, and I know that they've done a lot to get people indoors, but there's still a growing population that's very hard to document and count that is still outdoors without adequate sanitation, without access to water, especially under the heat wave that we're experiencing right now, and it's going to be sustained. And I want to understand the public health response to that particular population, which may not be very large, but they are certainly the most vulnerable. And so being able to understand where they are and how to reach them, and also how to help and support them is critical. So can you just elaborate on the strategy and plan that, or perhaps work plan that's underway to help this particular group of individuals?
So through the chair, I'll let me start by addressing this one. Certainly, we have worked with our partners at Shelter Support and Housing Administration and to a certain extent, the Housing Secretariat. Fundamentally, we know that this longer term solution is more sustainable housing. So that's certainly one of the areas that we're seeking to advance. That being said, we are in a lot of our focus, I will admit, has been on response for now and trying to support case and contact management and making sure that those who have been directly impacted and have had COVID-19 infection are able to isolate and recover in those facilities and settings that have been set up specifically for that purpose, for those who are experiencing homelessness and underhousing. And I know that I have meetings coming up in the next couple of days, actually one tomorrow to start off with our colleagues at Shelter Support and Housing Administration to talk about the next steps. How will we manage on a go-forward basis from balancing out public health and housing requirements in order to best support effective isolation and what I would characterize as true infection prevention and control for those who are experiencing homelessness and underhousing. We know that indoor congregate settings are particularly challenging for COVID-19 transmission. We'd like to see that minimized to the greatest extent possible.
Thank you. Mr. Chair, do I have time for one more question?
You do.
Okay, so my final question is, I certainly do recognize the objective is to get everyone indoors as safely as possible, and that of course is the current challenge, and I want to recognize that staff are working really hard to do that. But in the short term, the issue around sanitation, because the reality is that there is just not enough beds for everyone, and the beds that we do have may not be entirely suitable. And the beds that may have been secured in the short term, at some point, whether it's hotel contracts or interim housing, is going to run out. So I'm just trying to understand the city's responsibility to providing access to sanitation, in particular the life-sustaining source of water. I'm just trying to really understand what would be the public health response, not necessarily in the recovery, but in terms of the containment of COVID right now for those who are living and staying outdoors in encampments. Thank you.
So yes, through the chair, certainly we have heard of these of challenges experienced by being experienced by those who are in encampments, and in respect of water and access to facilities, our colleagues in other city divisions are leading the way on that. Certainly, we're keeping apprised and offering advice as best as possible. But those aspects, those responses are, being managed primarily through our colleagues, whether it's a little bit of parks, forestry, and recreation in respect of opening facilities, washrooms, and that kind of thing. I know that our colleagues at, SDF&A are also working on this front. So I'm happy to bring that back to city partners who have a more direct hand on the lever of control on those issues, and to ensure that the best is being provided for those who are experiencing homelessness currently in encampments, whether it's about access to water or access to appropriate washroom facilities and the like.
Thank you, Councillor
Mr. Chair, it's Julie.
Julie, did you want to add? That's our Deputy City Manager, Juliana Carbone. Did you want to add?
Is that okay, Mr. Chair?
Please, thank you.
So, Councillor, we're also working very closely with Tracy's team and, SSHA and others on moving people from encampments into temporary apartments, different housing options, hotels. So we are actively working on that. I think we've moved over 300 to date, and we continue on our efforts on that. So I can provide an update as well. I can call you offline, but I know you're familiar with our work in that area, and that will continue.
Yeah, no, thank you very much, Deputy City Manager, and as well as Dr. Davila. I guess what my question was trying to drive at, and I'm sorry I haven't been as clear, is that I know that by way of physical distancing requirement, we just had to get it done. So therefore, the shelters that were rather crowded were thinned out and open, and 33 new facilities were open so that physical distancing could take place. And that was driven by a public health directive that said this must be done. So I'm just curious, is there a public health, or should there be a public health directive that water sanitation should be provided? And we will sort out who needs to provide that, whether it's the province that comes in and helps or the federal government that provides some supports, retaining the support of Canadian Red Cross, or exclusively in the purview of the city. I'm just trying to understand, should there be a public health directive that says water should be provided for those who are sleeping rough? And that was really what I was trying to get at. Thank you.
Dr. Davila, did you want to answer on that?
Yeah, so through you, Mr. Chair, certainly, Councillor, what we can do is explore what options are available to us and how best to, to my mind, whether it's done under directive or without, how do we make sure that water is being provided? How do we make sure that access is being provided to facilities appropriately? Very happy to work with our city partners on ensuring that that happens.
Thank you.
Very much.
Thank you very much. And welcome to the virtual meeting, Deputy City Manager Carbone. Thank you. I know you've been here the whole time. Next, I have Councillor Lai. And can I just see by a show of hands, is there anybody else who wishes to ask questions as I'm finalizing the list here? Okay. Councillor Lai, over to you.
Thank you, Mr. Chair. And thank you, Dr. DeVilla and Liz, on the presentation and on the report, and these very, very good recommendations that are in there. I just wanted to understand a little bit better on the volunteer isolation and quarantine center system. Could you elaborate a little bit on what you're looking at here, what kind of system you're talking about in this recommendation here, please?
So through the chair, very briefly, what we have found is that with certain circumstances, there are some clients who find that they have a COVID-19 infection. And because of their housing circumstances, they may live in a relatively small space, perhaps with lots of other people. They are unable to manage an appropriate isolation. Right? So we know that one of the major risk factors for a COVID-19 infection is actually being a close contact of somebody who actually has COVID-19. And one of the most frequent places where that happens is in the household.
Yes. Sorry,
so
I understand
the notion
that.
is to,
I just wanted to see I understand the background and the rationale of it, but I just wanted to see what it is all about. Like, what is in the detail of this system here? What are you planning to achieve in this system?
Right. So effectively what it is to work with provincial and federal counterparts who've expressed an interest in supporting this, to establish, say, for example, a hotel-like facility where people with COVID-19 cases who can't do isolation well at home would be temporarily moved for the period of isolation with appropriate supports so that they can actually effect a good isolation, not make their other household members sick, and recover until such time as they can then come back into their homes. That's effectively what it is.
Would they be paid by the government, or how does that work?
Yeah, so none of the details have been really worked out, but if we were to use the examples of other jurisdictions, then the fee for covering for the isolation facility and the supports that are necessary would be covered by government agencies. And this was something that the province, to a certain extent and to a greater extent, the federal government has expressed interest in establishing and supporting.
Thank you. And there's a follow-up question on that one. I think I've asked questions before at the previous meetings about this issue, and you were telling me that there are some people that cannot isolate them, and on a case-by-case basis, the city is helping them. Is that correct?
So we do try to provide appropriate supports for those who are identified as COVID-19. What will it take to help them appropriately manage and limit infection?
And I've also, I think, asked questions about for those healthcare workers, just to ask the province whether they can provide them with accommodation during this pandemic, because when they go home, that will be a very high chance of they will transmit the virus. Is there anything that is happening on this issue here?
So through the chair, to my knowledge, I don't know of that particular program at the provincial level. I'm certainly happy to follow up.
Okay. And about contact tracing. So with this mechanism, this quarantine center mechanism here, would you be recommending that there will be a contact tracing of the person who's being quarantined?
So through the chair, that would happen regardless. It is happening now. This is just to provide them a space to effect a more safe and effective isolation.
No, I don't mean that. I mean that to, make them wear something so that we know them, that they're not really, they're staying in the quarantine place. They're not getting out to go shopping or to go grocery shopping or what, that is the contact tracing I'm talking about.
Oh, I see what you mean. Sorry about that. So through the chair, no, that the idea is that we would connect with the individual on a daily basis, as we do with all other cases, to make sure that you know, they're affecting a good quarantine, but they're not actually tracked, if you will.
Yeah, just one final question I have for you, Dr. Davila. Regarding the airport body temperature testing, I asked that question and you said that is they're in the Peel region and all that. Are there any progress on this collaboration with these authorities?
So through the chair, you're quite right. Any airport measures that are taken in screening of travelers is actually under federal purview. With respect to taking temperatures at airports, the last I checked of the literature, and you know, we tend not to get very engaged in this because it is under federal authority. But the last I checked of the literature, when we look at airport temperature screening, it's not found to be particularly helpful. But you know, the science is constantly changing on COVID-19. We can certainly look to see what the evidence is, but I'm quite certain that our federal partners who have this under their jurisdiction are actively following that literature and would be applying, I would like to think, the knowledge, the best available knowledge on how best to manage passengers and travelers.
Thank you. Those are my questions, Mr. Chair.
Thank you very much. And I'm going to put myself on here to ask questions before we move into speakers. So, Dr. Davila, on the accommodation facilities to support isolation for those who can't, in your recommendation, you're requesting the city manager to engage with our federal and provincial counterparts on this. Have there been conversations already with the federal government on this potential initiative?
Yes, there have been.
And has the federal government indicated both a desire and a willingness to partner with us and perhaps fund this initiative?
Certainly the desire to partner has been expressed. It's been some time since I heard an interest in funding, but my understanding is that is still there. We will pursue that further, though.
Okay, so they have previously expressed both a desire to see it and a potential willingness to fund it. What about at the provincial
Correct.
level? Thank you. And at the provincial level, both, have we heard whether they would like to see such a program and whether they too would be prepared to fund it?
At the provincial level, we've certainly heard of their interest in supporting it more from a work point of view and from an evaluation point of view. I have not heard specifically around willingness to fund the endeavor, but I will admit we have not specifically asked that question.
Okay, thank you for that. In terms of the criteria as to who would qualify for such facilities, I understand from your report the intent. For those who cannot effectively self-isolate at home, this would provide a safe manner by which they could to protect fellow household members. Have you started in Toronto Public Health to determine what the criteria is in order to qualify for such accommodation?
Yeah, so there has been some thinking put into this, some thought put into this, and there are some criteria premised on our own experience of clients and as well the experiences of other jurisdictions that have done the same thing.
And can you give us an early indication of what that criteria might look like?
So I don't have all the details in front of me, and I do apologize for that, Mr. Chair, but certainly household crowding would be one of the concerns, the number of rooms and the number of persons in the home, access to separate washrooms, that kind of thing. Essential workers, you know, and the ability for them to continue to provide those essential services. Those are some that come to mind, but I'd be happy to provide you with a complete list of the criteria that have been proposed thus far. I just don't have them with me.
No, that's very helpful. And in terms of the timeline, in an ideal circumstance, when would this open? From a public health perspective, should this be open now, tomorrow, yesterday? Just from a public health perspective, when would you like to see these open, not when they will open?
So we would like to see them right away. You know, while I admit our case counts, our new case counts are relatively low compared to what they've been in the past, we should be prepared and anticipate surges and increases in activity again. So sooner rather than later.
Okay, and so we'd like to see them right away. Based on the recommendation in front of us and the work to date and the conversations with the other levels of government, when do we expect these could open?
I don't have an exact date, but we are already working with our federal counterparts. Had conversation earlier this week and are continuing to move forward on how we might actually bring this, make this a reality sooner rather than later.
Okay, and then just to turn my attention to the discussion of a potential increase in cases in the future. You mentioned just there that we need to prepare ourselves for a potential increase in cases. People refer to the second wave. Based on what other jurisdictions around the world are seeing in their response, along with their reopening, what is the best estimate at this point for a potential second wave for the City of Toronto and this country?
So through you, Mr. Chair, difficult question to answer. It's hard to know. Again, unprecedented virus. Are we going to continue to see a bit of a slow burn and then some kind of increase in activity? Will we actually get down to zero and then start to see an increase in activity? Very difficult to say. I think there's been a lot of speculation and thought that as respiratory virus season starts in October-ish, that we might actually expect to see increased activity of COVID-19. But I would also suggest that as people move as a result of cold weather into indoor environments, while there is virus circulating, and we know that the risk of transmission is higher in indoor settings, that we should expect to see increased activity as people retreat into the indoors given colder weather.
Okay, those are my 5 minutes. Thank you, Dr. Davila. At this point, we're going to move it into committee for speakers. And so can I, just by way of a show of hands to create a list here, who wishes to speak on this item? Okay. I see Councillor Wong-Tam, Councillor Lai. Now, is Councillor Perruzza still with us? I had promised members of our board a first. No, we no longer have Councillor Perruzza. Okay. So we're going to move into speakers. I have Councillor Wong-Tam to be followed by Councillor Lai. If there are other speakers, you can indicate by show of hands, but we will begin with Councillor Wong-Tam.
Thank you very much, Mr. Chair. And as we always now have become accustomed to, we begin our remarks by extending thanks and gratitude, heartfelt gratitude to the extraordinary team at Toronto Public Health, to you, Mr. Chair, for your leadership, ongoing leadership during the COVID response and hopefully path to recovery. Dr. Davila and your team, I know it's been very difficult. It's been difficult to telework, to be quite honest, and it's certainly very, very difficult to be on the front lines. I am incredibly encouraged by the attention, the issue around disaggregated data and recognizing that people with vulnerabilities experience COVID and this pandemic differently. I recognize that this particular body, the Board of Health, has always been a thought leader in advancing health equities and addressing the social inequities when it comes to who gets to stay healthy and who doesn't, who has access to housing, who doesn't, and all the myriad of factors that play into that particular conversation and that drive outcomes. I am incredibly distraught and worried, and I have been for some time, about those who don't have access to housing, who do not have access to proper medical supports, who don't have access to recovery beds if they're living with addictions, and who don't have access to safe supply, who don't have access to, in this case, access to sanitation and water for those who are living outdoors. Toronto's an incredibly rich city, and I think we can all be very grateful for the resources that we do have. I do fear that there is a particular group of individuals who are falling through the cracks even further and further. And they are no longer hidden from us. They are now in entirely plain sight. And it comes back to the issue of not having adequate, suitable long-term housing. And we know that that has to be the ultimate pathway for people who are living on the streets and who are street involved, which are predominantly also Black, Indigenous, racialized people, and women when it comes to how poverty affects, those of that particular gender. And also LGBT people and those who are non-binary. So I know that everything is being mustered in terms of all the resources and all the powers that the city has. But I would just say this, and I hope that it's not a criticism, it's just something I want to put out there. When leadership at the city, and this includes us as the Board of Health, but there are others who sit at tables that we don't have access to, those who sit with the premiers and who sits with the premier, who sits with the minister, who sits with the associate deputy ministers at those other levels of emergency table responses. I just want to say that it is critically important to make sure that the request for supports for those who are on the streets, who are living without adequate housing, not just the underhoused, but just without housing at all. Like, they need to be made aware of their responsibility and the fact that we need their support in order for us to address the crisis that impacts everyone differently. And I know that there's many requests. I recognize that the laundry list as we appear before our provincial and federal counterparts is incredibly long. I get that. But I just want to ensure that our requests and call for intergovernmental action is there. Because what I think is happening, and I'd like to be proven wrong, but as we move forward with sort of a global request, that global request usually has a few people falling out of the margins. And those few people are now thousands of people who are now living on the streets, who are living without homes, and then the in-betweens. And I just want to make sure that when those opportunities arise, when we are at those tables with the senior levels of leadership with the other orders of government, is that we remind them that the 33 facilities that the city has booked temporarily at some point will come to an end. Whether it's community centers that we have to return back to regular programming, or schools when we work with the school board to provide temporary respite centers, or if it's hotel rooms where the contracts will come to an end, or if it's interim housing, those facilities will come to an end at some point in time, which means that the population that has been temporarily moved into alternative indoor accommodations to make room, the social distancing required in the crowded shelter system, it means that they may not go back into the crowded shelter system because the mindset will be that they're still not safe with or without a vaccine. So we are heading into a even bigger crisis than I see the one before us. And that crisis is going to be compounded by the fact that we don't necessarily have a financial plan to address the challenges that we are seeing today. And I know that that's not because the staff are not trying. I know that the staff are working really hard. But the bigger crisis is that we're going to be at coming to the end of the year. We're facing a multi-billion-dollar deficit. We have a growing population around homelessness that continues to expand exponentially. And I'm just really incredibly nervous and frustrated and angered, to be quite honest, not at anybody here, but I'm angered by the lack of attention being paid by the province and the federal government to what I think is a humanitarian crisis around homelessness and COVID. And that is really alarming. I just want to make sure that we don't hold back when we go before the other orders of government at those intergovernmental tables, because I know they have been established. And I want to make sure that this particular group of individuals has equal and fair, equitable representation at the table when their issues are brought forward by the leadership who is actually sitting at those tables, so that we ask the Premier and eventually the Prime Minister and the ministers, what are they going to do to help Toronto in dealing with the homelessness challenge that we have today?
Councillor, I'm just going to ask you to wrap up there.
Yeah, and then make sure that we put a gender and equity lens over all of that, because that's critically important in shaping the response and the recovery. Thank you very much.
Thank you very much, Councillor.
Point of order, Mr. Chair.
And I was just about to call on you, sir. Councillor Perruzza, you had a point of order.
Not really a point of order. I just wanted, I know that you would have listed me down to speak, and you would have done that before you went into committee, but my battery on my pad died, and I tried to frantically get it back up, and I'm back on now. So thank you. I saw you had rejoined, and I was about to call on you next. If you're prepared for that. Absolutely. Thank you so much.
Wonderful. So we're gonna turn it over to Councillor Perruzza, and then we have Councillor Lai, followed by Director Mulligan. So Councillor Perruzza, welcome to the Board of Health, and you'll have 5 minutes when you're ready, sir.
Sure. Well, first of all, listen, thank you so much. I know that you're entertaining a motion today that seeks to ask the province to bring one of these mobile testing units up into the northwest part of the city of Toronto. And I want to thank you for that. As the chair, I know you've taken the lead on this, and really appreciate it. And I also want to thank Dr. Davila and her team and her staff and her efforts. I know this is a real tough job. I also want to give you a location if you choose to consider it. The Christian Center Church, 4545 Jane Street. It's up on Jane, just north of Finch. We've the pastor is aware. They have a big site there. They would welcome it they would welcome the unit, the mobile unit there, and it would be in the middle of one of your so-called hot spots. So hoping that somebody is making a note of that, and they might follow up. We'll certainly follow up with you as well. I can't imagine how hard this is. And in the conversations that we've been having with people here on the ground, this is a very interesting community. And I know that you're doing a lot of data collection and you're looking at people, but, I, for example, me, Anthony Perruzza, if I felt a twitch at the back of my neck, I'd be at a testing center. I would take myself there, I would drive myself there and get tested because I understand the importance of all of this and the importance of containing this otherwise invisible to the naked eye bug that just seems to want to hop around all over the place and all over us. The problem is that the bug itself camouflages itself so well in people that experience, that are, with the word you're using, the technical word is asymptomatic, but people who experience very little by way of, physical distraction, let's say, either sore throat or kind of runny nose, slight cough, and if I live up here and I'm struggling to survive and pay the rent, bouncing from my, part-time jobs or just simply bouncing, trying to figure out, how I'm going to, connect to the next dollar to kind of, get by. I'm not watching the news. I'm not on CNN. I'm not following all of this stuff. So I'm not getting the information. And if I feel a twitch in the back of my throat, I probably think it's just kind of like, oh, you know what? I didn't sleep well last night, or something I ate, or something I drank, or, slight cold. And I'm not going to get myself to a testing center because it's very, very difficult to do that. And the other problem that we have is we have language barriers, people aren't, they're not following this stuff. So what I think we need to do is we need to get a lot of boots on the ground in these neighborhoods to find a way to contain this bug, to locate it and then isolate it, right? That's the way we're going to deal with it. And I know we use all these terms about contact tracing and all the rest of it, but really you need to get to the folks that where the bug is harboring itself and it's moving around, it's hopping around because the person doesn't know or doesn't feel the symptoms deeply enough to go get tested. So we need to get people out there. And what's been suggested to me by some of the local people on the ground doing the work up here is what you need to do is you need to activate that legion of people, that network of people that you have in neighborhoods who are disseminating information to others and connecting to volunteers and so on, and going to these places where people otherwise congregate, where they have to go through, the malls and the shopping places where eventually they have to end up. And getting that information out there to them in the variety of languages. I know it sounds like a lot of work, and I know it sounds like you need to go out and touch a lot of people, but that's what we need to do. If we're going to be successful at finding the bug, where it loves to sort of hide and hop around, right? Until then it bites somebody who's got these sort of those underlying conditions where it could take their lives. That's what we need to do, and I understand that it's a monstrous amount of work, but that's what you got to get the boots on the ground, and you got to and this is what we need to do. So I appreciate the mobile unit, really do, but if it doesn't come with the bodies on the ground to actively do that sort of that touching of people, locally, to get them to get tested, and then to find the bug and to isolate it in those folks, then I'm afraid that we just keep going in circles with it. And I understand that. I imagine Dr. Davila goes home at night and spends lots of nights thinking about this, but those are my comments on this, Mr. Chair, and thank you for your help in this regard.
Thank you, Councillor Perruzza, as a visiting councillor, for joining us here today as well. Next, I have Councillor Lai, when you're ready.
Thank you, Mr. Chair. I'd just like to start by thanking again Dr. Davila and your team for this amazing job that you've been doing in protecting us, our city, from COVID-19. We just cannot thank you enough for all your hard work, and we know that this is a new virus, and everybody's learning from it, and hopefully, and we're also learning from the other jurisdictions that have it, and then maybe before us or ahead of us. And really thank you for your advocacy to the other levels of government and all your tireless efforts and to make sure that we are safe. And in particular, I'd like to thank you on behalf of my residents and from the business owners that attended my roundtables on this COVID-19 recovery is about the mandatory wearing of masks. And I really thank you, and they thank you too for your leadership and for listening to them. And it is very important that, like I said, this is a new virus, and there are the signs and all that. We know that, and you are the experts, and we really appreciate what you've done to making it a reality. There are many, and I also thank you, Dr. Davila, by sharing all your touching stories of your staff. And I'm sure that there are many other touching stories in Toronto. There are many tons of acts of kindness during this COVID-19. That because we are into this together, and it's only by collaborating together that we can get through this together. It's very important to be proactive, like I have always said, and to protect our city from our second wave. And this recommendation that is before us today is very good, and I will support it just very in a heartbeat. I will support this because this is really important for us to be proactive. On closing, I'd like to actually thank our chair, Councillor Cressy. You've been showing your leadership in this, and even you have postponed your maternity leave, and really appreciate that. And your communication with us as board members is to be commended. Thank you.
Thank you, Councillor Lai. Director Mulligan.
Thank you, Joe. I also want to commend you and Dr. Davila and the TPH team for your very hard work and leadership during this time. I know that we're in a new phase of exhaustion from all of this. And I really want to recognize the leading work that the city has put in to really trying to take action on health equity and data and the social determinants of health. We still have a long way to go. But one thing that has been absent from the pandemic response in some other levels of government has been a real transparency about the data, about the work, about who's most affected, and about how what we know is going to inform what we do. And I'm just very pleased with today's presentation about the data that shows the hard work that you've put in collaboration with the province to build up the infrastructure to support the fantastic analysis that Liz and her team have done on the data. I also want to recognize you, Mr. Chair, because there are some boards of health in the province that still haven't met. And it is important for us to continue reflecting on the role of a board during a pandemic. What's our place? What influence can we have over what's going on? What do we need to know? And how do we share that better with the public? So even today, for example, we only had 2 deputants. I think we can do better. I think people need to know and need to participate and need to be part of these conversations about not only our pandemic response, but also these growing conversations about our future. The conversations about the future are at risk of being highly inequitable as well, because some people are still dealing with the emergency of the pandemic, while others are able to breathe a little and start thinking about new futures and new ways of doing things. So I'm happy to hear that Toronto Public Health has made such a commitment to including community, the expertise of community voices in both the emergency response and the testing, bringing mobile testing where it's needed, relying on the expertise of community organizations who have the trust of the community and knowledge of the community, as well as in those conversations about what are the policy responses that we might need into the future. So I'm very happy to hear that, and I think it's very important for us to recognize the importance of democracy and transparency in the work around COVID as we move away from maybe an initial highly centralized emergency response to something that we can all participate in a little bit more. I want to highlight long-term care again. And the reason is that, well, in addition to it being a major hotspot for COVID-19, people are really suffering in long-term care for a number of reasons. And the one that I want to highlight is isolation and loneliness. We have reports of people dying of isolation and loneliness, of people experiencing significant cognitive decline, significant physical and mental health challenges that may not be reversible at their age and stage. And yet we still don't empower family and other caregivers to enter these homes in a way that is supportive of the health and well-being of these residents. And so I know that Dr. Davila mentioned that this is primarily the purview of the province. But if it's possible for the City of Toronto to take leadership on things like masks, on things like equity, on things like data, I think we need to think about other ways that we can take leadership on people's social support networks as well, and to recognize the importance of these informal caregivers as vital parts of care teams and not as quote unquote visitors. The last thing I'm going to say, and it's related to that, it's around the importance of the social determinants of health and people's social networks. And that is that I've asked the chair to add one recommendation that he will be moving in due time. And it's around social screening and referral and tracking for people who are tested or tracked for COVID-19. And it's another way to address the social determinants of health that we have seen are so vital and so important for people: housing, income, racialization, gender and sexual identity, and so on. These are all really critical. And loneliness and isolation is a significant one as well, and one that's really become even more significant in this time of lockdown and isolation. So we need to not only address the fundamental social determinants of those inequities, but also the social needs that arise in real time. The COVID screening is an opportunity for us to identify people's social needs and meet them in real time. And so this is why that's there. The work on social prescribing that has been undertaken in other jurisdictions.
Director, I'm just going to ask you to wrap up. I've given you 8 minutes so far.
Okay, I'll end here. The work shows that it's highly valuable and helps to demonstrate the importance of public health work. Thanks so much.
Thank you so much. Last call, are there any other speakers on this item? I didn't have anybody else. Would anybody else like to speak? Okay, I will speak here now then, and let me begin by placing the amendment that has been advance circulated. And for everybody's benefit, I'll very briefly address some of the things that are new in here. Item 2B, that the board supports the expansion of active TO measures to provide safe and physically distanced alternatives for transit. In item 3B, as part of the data analysis, as Dr. Davila mentioned and Liz, that to work in partnership with the Health Commons Lab, Solutions Lab, as well as other community groups and individuals who are most affected. In 4B, which is as part of our September meeting, to report back on immediate and long-term policy measures to protect those who are most at risk, including but not limited to specific measures to consider for people on low income, in racialized communities, newcomers, people living in unaffordable or inadequate housing, and people who in various occupations that are overrepresented in COVID. As well, there is to report back on the potential for social needs screening and referrals, as Director Mulligan was just speaking to. In number 5, as part of our recovery planning, to consider food security, specifically food access, affordability, and the specific needs related to the Black community. And finally, as visiting member Councillor Perruzza spoke to, in item 6, to urge the provincial government to ensure that their testing strategy is focusing and takes into account the high-risk areas that we're identifying in the data analysis, and that in particular in our city includes and means the Northwest. So I will move those. It's been 26 weeks. I know at the beginning of every meeting I give a bit of a time check on this, but it's been 26 straight weeks of public health response on this file. And while we're in the midst of a storm, at times you sort of take a step back and you realize the profound tragedy and destabilization that this moment in history has brought. And it's hard to take a step back because we're so focused on working. But we have no choice but just to keep working. I mean, this is a case where our residents are counting on us and our city is counting on us. And so amidst the storm, we plow ahead. And in doing so, as I will do at every meeting, going forward and perhaps forever, I will thank our Medical Officer of Health, Dr. Davila, again for her unwavering leadership and her non-stop work in the entire Toronto Public Health staff team. You got a sense today from the presentation from Liz of just how deep our bench strength is in TPH and how exceptional our staff are. I will tell you as a board and as a city, I am proud of the work we've done to date. We've always said that we're going to do everything always, and we're going to seek to do it early, and we're going to follow the evidence and follow the experts. And by virtue of that approach, we have been, as a public health unit, the first in the country to do many things, whether that's the collection and in turn sharing of disaggregated data, whether that's the proposal here today to initiate COVID isolation accommodation options for the underhoused, or whether that's in partnership with other divisions at the city, the establishment of homeless recovery and isolation facilities. All of these measures were life-saving and critical. All of these measures were the first in our country. Being the first doesn't mean, however, that you get a pat on the back. I believe it means we commend the good work and then we go and do more of it. We do more of it in part because there's likely a second wave coming. And it's almost hard to say that, given how tiring the last 26 weeks have been. And in many ways, in preparation for a potential second wave, it's a bit of a race against time. It's a race to ensure that all of the necessary public health systems are in place at the federal, provincial, and municipal level to prevent outbreaks in the general population. That's a race we must win. But it's also a race to ensure that the necessary preventative measures for the most vulnerable are in place. You know, the presentation we received today, collecting data is not the outcome. Collecting data is the launching point for further actions. And so when it comes to a potential second wave in this country and in this province and in this city, there will be no excuses. There are no excuses to see a repeat of what happened in long-term care. There will be no excuses if we're not ready in our shelters. There will be no excuses in migrant farms. There will be no excuses if we let the poor in our city down. That's the race. When I consider that race, I will tell you on a personal level that just like every resident in our city, those working on the front lines and those otherwise, I'm tired. I think like all of us, we're trying to live in a moment while at the same time preparing for an uncertain future. And I desperately want our city to return to normal. But normal wasn't good enough for far too many residents of our city. The data has exposed that it's those pre-existing health inequities that COVID is taking advantage of. It's the people working in precarious frontline jobs who are most at risk. It's people living in crowded, underhoused settings who are most at risk. It is racialized people who are most at risk. And so while I desperately want to return to normal, and we desperately want this period in history to end, returning to normal isn't good enough for those we need to take care of. And in the world of public health, for too long, we've yelled and screamed about the negative health consequences of poverty. We've written report after report, study after study. We've made endless recommendations to the city, to the province, to the federal government. Now is the time for the governments to act. There are no excuses in a second wave anymore. It's our time. And with that, I will once again thank Dr. Davila, members of this board. We have a long road ahead, but we can't let our residents down. Thank you very much. With that, we have an amendment in front of us. Is there a willingness to take the amendment along with the staff recommendations as a package? Okay. I'll do this by way of a hand vote, unless there's a request for a recorded vote. All those in favor, by show of hands. Any opposed? Councillor Wong Tam, your hand is up for opposed. Is that in favor? No, it's okay. So any opposed? Seeing hands, seeing none, that carries unanimously. Thank you. The final item here was a new business item that we put on the agenda. This is item HL 18.5. I submitted it as a letter of new business, which is a request for the medical officer of health to report by the end of this year on the status of our work regarding a public health approach to community violence. Does anybody have any questions on that item? Okay, seeing none. I will move the speakers. Anybody wish to speak? Okay, seeing none, I will move the recommendations contained in the letter. All those in favor? Opposed, if any? That carries, and that takes us to the end of our meeting. Thank you again, everybody. For those of you who have the joy of getting away or spending time with your family this weekend, please do so safely. And we will talk to you all very soon. Thank you again, and thank you to our clerks, staff here today for all their hard work. Goodbye for now.